So hi guys, I'm Dr. Sumit. I'm a first year postgraduate in Department of General Medicine. So in this video, I'm going to talk about the optimum management of patient with heart failure with reduced ejection fraction and heart failure with preserved ejection fraction. So these are the contents I'm going to cover in this video, and like the burden of heart failure, definition, classification, pathophysiology, diagnostic approach, GDMT, that is guideline directed medical therapy for heart failure with reduced ejection fraction. Then some landmark trials. We'll see the landmark trials and all that thing, and heart failure with preserved ejection fraction in depth, and advanced heart therapies and acute heart failure and future directions. So these are these are taken from the recent advances in general medicine. So this is the burden of the heart failure. You can see these are the 64 million, more than 64 million people are living with heart failure worldwide, and 60 to 65% proportion in the Indian heart failure is due to heart failure with reduced ejection fraction. Whereas in 50, it is 50-50 ratio. 50% is due to reduced ejection fraction, whereas 50% is preserved ejection fraction in the Western countries. And the mean age is 60 years in India, which is a 10 years earlier than high income countries like Western countries, yeah. And about the sex predominance, male predominant 60 to 70% in India heart failure history, whereas it is 50-50% in Western countries. So these are some registries like THF Trivandrum heart failure registry, then Kerala heart failure registry, National heart failure registry, and Indian College of Cardiology. They came with a conclusion that ischemic heart disease contribute to nearly 75% of the burden of heart failure in India, and dilated cardiomyopathy contribute to 11 to 18%, and rheumatic heart disease 3 to 8%. So that means these three diseases, ischemic heart disease, dilated cardiomyopathy, and rheumatic heart disease, contribute more than 95% of the Indian heart failure. Correct. So these are some phenotypic distribution, and as I told earlier, 60 to 65% of the heart failure, Indian heart failure patient is of with reduced ejection fraction, whereas in Western country it is equal split, 50% preserved, 50% reduced ejection fraction. uh, and so yeah, and this about the coming to the definition and classification. So this is the definition. So heart failure is a clinical syndrome with symptom and or sign caused by a structural or functional cardiac abnormalities, corroborated by elevated natriuretic peptide levels and objective evidence of pulmonary and systemic congestion. So this is the so HF is diagnosed based on clinical features, and it is supported by elevation of natriuretic peptide in the blood. It should be more than 125 picogram per ml in ambulatory patient, and more than 300 in decompensated or hospitalized patient. These are the table. These are the symptom and sign of heart failure. So some typical symptoms are there like breathlessness, orthopnea, PND, then reduced exercise capacity, fatigue, tiredness, pedal edema. More specific signs like elevated jugular venous pressure, S3, and evidence of cardiomegaly, X-ray. So this is the staging of heart failure. So stage one is the patient is at risk. For example, the patient has hypertension, diabetic, but there is no structural disease, there is no symptoms or sign. So we call it as stage one. Stage B is structural disease is present, but there is no symptoms or sign. Like incidentally, when we do a 2D echo, you got to know that there is structural disease is there in the heart. So that is stage B. Stage C is structural disease is there with current or prior symptom. Stage D is there is advanced heart failure and there is refractory heart failure. Refractory heart failure means even after using the GDMT, that is the guideline directed medical therapy, still the patient has a symptom inside. Okay, so this is the classification of the heart failure based on the ejection fraction, left ventricular ejection fraction. When it is equal to less than 40%, we call it heart failure with reduced ejection fraction. When it is 41 to 49%, we call it at heart failure with mid-range ejection fraction. Heart failure with IMP, that is improved ejection fraction. So that is baseline ejection fraction is less than 40%. For example, the patient came to first time to the OPD, we check when you do the 2D echo, you find that the ejection fraction is 36%. With next follow-up rise after taking the medication, if it is more than 10%, more than 10 points, or it is more than 40%, then we call it as the heart failure with improved ejection fraction. And with preserved ejection fraction is more than or equal to 50%. Correct. So these are the some selected. These are the causes of heart failure of reduced ejection fraction and preserved ejection fraction. So this is the table taken from Harrison. Okay, yeah. So this is the pathophysiology. So pathology is based on so when there is a decrease in the cardiac output, and there will be activation of RAS mechanism, there will be a sympathetic nervous system activation. So in turn there will be angiotensin 2, aldosterone, and norepinephrine will increase, and they will do the vasoconstriction. They will do the salt and water retention, and in turn they will do the chronic myocyte injury, inflammation, and last they will do the fibrosis. And once there is a fibrosis is present, that will cause the pathological ventricular remodeling. For example, chamber dilation, then wall stress, So this is the diagnostic approach. Once the patient comes to the casualty with, we suspect it as heart failure. For example, the patient has dyspnea, fatigue, edema, elevated JBP. For example, your DD is heart failure. You check for NT-pro, BNP level, and BNP level. If it is more than 125 in ambulatory and more than 300 in decompensated or decompensated hospitalized patient, you do one 12-lead ECG, chest X-ray, or do one echocardiography, then and classify them based on the ejection fraction, like it is reduced or it is mid-range or it is improved or is preserved. Okay, so this is the main part of our discussion, GDMT, that is the guideline directed medical therapy for heart failure with reduced ejection fraction. So this is some non-pharmacological measures like vaccination, nutrition, exercise, salt intake, fluid intake, obesity, and weight management. So this is the salt intake. Is excess dietary sodium is a common trigger for worsening of the congestion and heart failure, exacerbation in heart failure with reduced ejection fraction. So these are some evidence based on sodium heart failure trial and meta-analysis of the randomized control trials. It's found that there is no routine fluid or salt restriction should be advised to the patient if the patient is clinically stable and the patient is euvolemic. There is no signs of congestion, that then there is no need to restrict fluid and salt. Okay, and about the nutrition, you have to correct the cardiac cachexia should be managed properly. You have to correct the vitamin deficiency like the iron deficiency, vitamin, and obesity. Yes, so obesity is an important thing. There is a called obesity paradox. So it's seen that obese heart failure patient often have a better survival than a lean heart failure patient. Correct. So patient, for example, if the patient has obese but the BMI is less than 35%, then no need to ask for a reduction of the weight. If it is more than 35, then the reduction in the weight will help the patient. So there is select trial is there. It says that semaglutide reduce the obesity and decrease the heart failure hospitalization. So next is exercise training. So regular aerobic exercise and respiratory muscle training is advised to the patient. Vaccination, annual influenza vaccine and pneumococcal vaccination should be advised. So these are the GDMT. So there is first line GDMT and second line GDMT. We'll discuss the first line GDMT. There is four pillars of the heart failure. So first one is SC, ARB, and ARNIs. Beta blocker. Second is beta blockers. Third is MRA. This is a mineralocorticoid receptor antagonist. Fourth is SGLT2 inhibitors. And so there is this strong heart failure studies there. Safety. This is a full form. So it trial proved that if all the four therapies are started as soon as possible, preferably while the patient is still in the hospital, and it should be titrated up over the next 4 to 6 weeks, the rate of hospitalization and mortality is significantly reduced. Okay, so now we'll discuss the each of the pillar. So pillar one is RAS and ARNI. This is the SC inhibitors, ARBs, and ARNI. Okay, so mechanism, I think all of you know. I'm not going to discuss it. These are the mechanism, and these are some landmark trials. So consensus trials, it says that enalapril reduce all cause mortality by 40% at 6 months. So after that, RAS1, so the RAS1 become the first pillar for the heart failure with reduced ejection fraction. Paradigm shift heart failure, it says that ARNI versus enalapril, it says 20% risk reduction rate in CV death. है Next is this is the MRA. This is the second, the mineralocorticoid receptor antagonist. So spironolactone or eplerenone. It blocks the aldosterone mediated sodium retention, myocardial fibrosis, and adverse remodeling. Okay, so these are some trials, landmark trials like RAILS trials, Emphasis, HF trial. These are some side effects like hypotension, then fall in GFR, increase like hyperkalemia. The three major side effect of ACE inhibitors, ARB, ARNI, and mRNA. These are the practical pillars. You should not use those two pillars. This is the ACE, ARB, ARNI, and MRA. If the GFR is less than 30 or the SBP is less than 100, systolic blood pressure is less than 100 mm per Hg. And if the serum creatinine is 2.5 or it is more than 20% on the baseline, reduce the dose or temporarily stop the ACE, ARB, and ARNI. If the potassium is more than 5 but less than 5.5, you have to use it cautiously, especially with MRA. And if it is more than 5.5, stop all the SC inhibitors, ARB, ARNI, MRA until the potassium normalize. Correct. So these are the some dosing. So starting dose is important, target dose is also important. Then beta blockers. The pillar 3 is beta blockers. It will counteract the overactive sympathetic nervous system. Okay. These are some landmark trials like CBS2, this Merit HF trial, this is a Copernicus 2001 trial. These are some trial. These are some doses. So bisoprolol starting dose is 1.25, carvedilol is starting dose 3.125 mg twice a daily, and target dose is 25 mg twice a daily. Metoprolol. Okay, and the thing is only bisoprolol, carvedilol, and the metoprolol have the mortality trial evidence for heart failure with reduced ejection fraction. Okay, so the two inhibitors, these are the newest pillar. The latest pillar is SGLT2 inhibitors. So these are the some landmark trials like Empiric outcome, Declarative Me, Canvas, Cadence, Emperor reduced, Emperor preserved. So these are some full form and the year of the studies. Okay, so these are the SGL2 inhibitors. The examples like dapagliflozin, starting dose is the starting and target dose both are 10. Empagliflozin also both same starting 10. Starting and target is 10 mg OD. Okay. So how to titrate these four drugs? So once the patient is stabilized, you have to start all the four drugs, in parallelly. So first example, from the first pillar, we'll take the ARNI, we'll take the Sac-Well, and from the second, we'll take the from the MRA, we'll take the spironolactone. So Sac-Well, spironolactone. From the beta blocker, for example, we'll take this carbidopa, and from the last, from the this last SGLT2 inhibitors, we'll take the this dapagliflozin. So these four drugs should be, should I should give it to the patient parallelly. And additional therapies like iron, this is the FCM, this is the ferric carboxymaltose, if to start in heart failure with preserved ejection fraction, if the iron deficiency is there, like ferritin is less than 100 nanogram per ml. These are some evidence like FIM, AHF, Ironman, and confirm heart failure trials. So these are some full forms are there. Evaporatin you can use when the resting heart rate is more than 70, despite the optimal, BB therapy, like beta blocker therapy, or when the beta blocker is contraindicated. So these are some trials. SHIFT trial is there. Okay. This is the omecamtiv mecarbil. These are the cardiac myosin activator. So this is the Findenol. So Findenol is shows that similar reduction in the, NT-proBNP and the hyperkalemia rates compared to the eplerenone, and also it reduced the incidence of heart failure. So GLP-1 receptor agonist liraglutide is, from the trial, it shows that the result were neutral. Okay. So and exenatide. So exenatide, it shows that it is increased risk of heart failure hospitalization. So there is no point of using of liraglutide and this exenatide. So these are some studies based on, for that live study, fight study. This is the Excel study. Okay, so this is the dietary therapy. So diuretics are for only for symptomatic control. It do not give any mortality benefit to the patient. So yeah, so loop diuretic like furosemide, torsemide, butamide, bumetanide you can use. These are according to the dose trial. There is no difference in the, high dose versus low dose versus, or bolus versus infusion strategy. And you can add thiazides, metolazone when the loop diuretics response is inadequate. Also, you can use the acetazolamide. So advert trial says that added when it is added to the loop diuretic in acute decompensated heart failure, there will be faster or more effective decongestion. And this is a trade heart failure exploratory diuretic withdrawal cohort. It says that when you stop the diuretic, when the patient is asymptomatic and you stop the diuretic, the patient may report, dyspnea again. Okay, so these are some trials. Yeah. So these are some landmark trials. These are the list of some landmark trials. You can take the screenshot from here. They all have the, the name of the trial, the what drug they did the trial on, then the population and the key result and year of study. So yeah. So this is the some trial spotlight. So paradigm HF trial. It says that ARNI now preferred about the ACEi as first line RAS blockade in heart failure with reduced ejection fraction. That is the sacubitril valsartan combination you can use. And from the Emperor and the Emperor reduced and the Emperor preserved trial, it says that SGLT2 inhibitor like empagliflozin, dapagliflozin are the class 1 recommendation with reduced ejection fraction, and it is a class 2A1 in, heart failure with preserved ejection fraction as per the 2022-23 guideline update. And fine arts heart failure and stave HF with preserved ejection fraction. It says that, this in future we may get Findenone as the, fifth pillar of the heart failure management. Okay, so coming to the heart failure with preserved ejection fraction. So if for example, the patient, 72-year-old female came with a complaint of dyspnea on exertion, and ejection fraction is, when you do the 2D echo, you find that the ejection fraction is 60%. Now the question is like, is it preserved ejection fraction, or it is due to COPD, or it is due to obesity or anemia or pulmonary hypertension? There can be a lot of possibilities. So for that we have to, there is a diagnostic framework is there, like H2FpEF score and HFpEF algorithm. For example, this is the H2FpEF score. This is a heavy BMI. If it is more than 30, you give a point of 2. Hypertension, if he is using more than equal to 2 antihypertensive drug, we give a score of 1, like that. Pulmonary hypertension, AFib, elderly, filling pressure, So these are some score, and when the score is 6 to 9, if it is between the 6 to 9, there is a heart failure with preserved ejection fraction is very likely. Okay, and for treatment, these are some evidence-based treatment of heart failure with preserved ejection fraction. So SGLT2 inhibitors is the DAPA and IMPA are the two class 1 recommendation. Is recommended for all the heart failure with preserved ejection fraction patient as per the Emperor, preserve and deliver. Okay, and emerging and recently positive results like Findenon you can use. Yeah, and steroidal MRA, spironolactone is a controversial role. A top cat trial shows that the result were neutral. Okay, so and supportive treatment is diuretics for congestion and aggressive treatment for comorbid drivers. We saw that hypertension, obesity, AFib, and coronary disease, deconditioning all can cause the all these are these are the parameters we used in this score. So we have to address that disease and you have to treat that condition. And ACE inhibitors, ARB and ARNI, these are not indicated in heart failure with preserved ejection fraction. These are some device-based therapy in heart failure with preserved ejection fraction. First one is ambulatory pulmonary artery pressure monitoring. So there is a device called cardio MEMS heart failure system. So this is the device in you have to this device is placed in the pulmonary artery, and the doctor sitting like somewhere remote can see the pressure in the pulmonary artery, and based on that he can titrate the diuretic dose and vasodilator. Other is intra-arterial shunt device. So intra-arterial shunt device, it create a control left to right shunt to decompress the elevated left arterial pressure. So there is a this connection is there between the right atrium and the left atrium. So when there is a pressure increase in the left atrium, so before it can congest the lung, the pressure is go to the right atrium, and yeah, so and it will avoid and it will reduce the chances of congestion. And these are some advanced therapies and acute heart failure. So these are some advanced therapies like resynchronized therapy, CRT therapy. So it is indicated in the when the left ventricular ejection fraction is less than or equal to 35%. If there is a left bundle branch block with QR is more than 150 ms. For example, there is a LBB block. So LBB block means the right ventricle can contract, whereas left ventricle cannot pump. So we'll do one synchronization. If there is a lead in the left ventricle, there is a lead in the right ventricle, and there is a pacemaker pulse generator is there. So pacemaker generate a pulse, and it will go to the right ventricular lead, left ventricular lead, so that the ventricle can contract in a synchronized way. Okay, so that is a cardiac resynchronized therapy, CRT. And next is ICD. This is the implantable cardioverter defibrillator. It is used as a primary prevention in left ventricular ejection fraction less than 30%, even after using GDMT for more than 3 months. Okay, so this is the ICD. So this is the ICD to prevent this VTAC, VFib. Then is left ventricular assist device, LVAD. It is to bridge to transplant. It is bridge to transplant or destination therapy in advanced stage D, stage D disease. So this is the LVAD, left ventricular assist device. So it will what will do? It will, when the left ventricular cannot pump the blood, so it will take the blood from the left ventricular and it will pump the blood to the aorta. Okay. Next, last stage is heart transplantation. So, but before heart transplantation, there is a temporary mechanical circulatory support you have to give. These are the IABP, like intra-arterial balloon pump, and Impella is there, and ECMO. This is the Impella, and ECMO. This is the ECMO. Okay, and these are some acute heart failure management. For example, a patient comes to the casualty, and you see the periphery. You have to check the periphery, and you have to auscultate the lung. If the periphery is warm, that means the perfusion is adequate. If the lung is congested, that means the patient is wet, means lung is congested, we call it as wet. So that means the perfusion is adequate, but the lung is congested. You can give the IV loop diuretics, you can add the vasodilator, and you can consider acetazolamide as per the ADVER study. If there is cold and wet means the heart is not pumping, it is hypoperfused. Wet means congested. So you have to cautiously you have to use the diuretics. You have to give the inotropic support. If it is cold and dry means the lung is dry. Cold means the heart is not pumping, hypoperfused. You have to give the inotropic balance. And in cardiogenic shock, you can have to give the inotropic support. You have to you have to early temporary mechanical circulatory support, as I told earlier. IABP, intra-arterial balloon, intra-arterial balloon pump, and then Impella, then ECMO, and you have to urgent revascularization if it is ischemic. These are some monitoring strategies in chronic heart failure. It's for you to check for the renal function and electrolyte. You have to do the serial NT pro BNP level, and daily weight and symptoms diary, blood pressure monitoring, then point of care ultrasound. Uh, and ambulatory PA pressure monitoring using the cardio MEMS device. And these are some future directions. So emerging frontiers in heart failure management, like using of artificial intelligence and wearables like watches, you know, and precision and personalized medicine, then novel therapeutic targets, some new device innovation. Okay, so these are some unmet needs and care gap in India. So GDMT remains substantially underutilized in real world Indian practice. And failure to initiate or titrate therapy, it contribute to undertreatment even if the patient is eligible or stable outpatient. And novel treatments and technologies for heart failure are still underutilized in India relative to the high income countries. These are some take-home messages. So you have to initiate all the four GDMT pillars, ARNI, SEARB. From here, from ARNI, SEARB, you can choose ARNI, that is the sacubitril valsartan. From the beta blocker, you choose the, for example, you choose carbidopa. From the MRA, you choose from the mRNA, if we choose, for example, spironolactone 25 body, and SGLT2 inhibitors, you have to choose DAPA or MPA10 body, and you have to start it parallelly. And SGLT2 inhibitors now shows the benefit across the entire ejection fraction spectrum. For example, it can be used in the with reduced ejection fraction, it can be used in the preserved ejection fraction, it can be used in the mid-range ejection fraction. And heart failure with preserved ejection fraction is a heterogeneous and systemic metabolic inflammatory syndrome. So the phenotype of the patient rather than treating it as a single disease. And iron deficiency should be actively screened for and treated with IV, that is the FCM. Not stop GDMT pillar for a manageable side effect. For example, if when you are using the ARNI, there will be a chances of blood pressure may decrease. There will be increase in the create. There will be chances of hyperkalemia. So that doesn't mean you have to stop this ARNI. You have to reduce the drug and you have to continue it. Okay, and preserve as many pillars as tolerated, and continue GDMT indefinitely even after the ejection fraction recovery. So even after the ejection fraction is like 50%, don't stop it. You have to use it for lifetime. Yeah. And the evidence based is evolving rapidly, stay current, and as the guideline recommendation for heart failure with preservation fraction are expected to strengthen further in future. So yeah, so these are some key references, and so yeah, thank you.